are IVF clinics that charge extra for services with fancy names that cost a lot extra that have no proven scientific benefit. These IVF scams were brought to light in a New York Times article in December of 2019. The name of the article was the Big IVF Add-On Racket. It was written as an op-ed piece in the New York Times, and it came from an article that came out of the HFEA, or the Human Fertilization and Embryology Authority, a group in the UK. They drew attention to various services and procedures that have no scientific benefit. Now, the HFEA is out of the UK, and I take a little bit of exception to the fact that they call themselves an authority. Granted, they're good-natured people with good intentions, and they are scientific, but there's some things that they state that I do not agree with. Also, you should realize that Europe has always lagged behind the United States in IVF success rates. For example, in 2018, Missouri Fertility, where I practice, had a 75.5% take-home baby rate for women that went to retrieval who were under age 35. 75% take-home baby rate is astoundingly high. It marks a new milestone in IVF success rates. In fact, we had an 83% take-home baby rate in women aged 38 to 40, which is just incredibly high. Now, we use some of the techniques that they tend to disparage, and we're going to clarify for you point by point which add-on benefits and add-on services we find truly beneficial. Now, they categorize their levels of caution as red and amber. Red, they want to say, warning, warning, something that does not have proven benefit. And we're going to take exception with one or two of their red warnings. They also have amber warnings, which are a little less problematic to them. And once again, we're probably going to agree with most of the things we say, but I will take exception with a couple of the points they make. So let's start with the red warning label procedures that they find are IVF scams. The first is something called assisted hatching. An egg has a shell around it, and when an embryo develops, it develops within this same shell. Making a hole in this shell is called assisted hatching. It can be done with a number of methods. Nowadays we use a small micro laser. Now, it was first purported to be of benefit to help embryos implant or help them hatch. And in that way help implantation rates. Now, if you can make an argument that making that hole does not help implantation. However, making that hole in the shell around the egg, called the zona pellucida, at day 3 of embryo development allows us to biopsy the embryo much more easily later in development. And for that reason alone, we find assisted hatching is very important. So I wouldn't we do it to everybody, and we don't charge extra for it. So they should take no exception with that policy and that lab procedure we do pretty much universally. There is something called intrauterine culture. They put a big red label on that, and we would agree with that. There's no benefit in putting an embryo in the uterus. The laboratory mimics the environment of the tubes in the uterus, and if someone's charging extra for that, there's certainly no benefit, and we don't do it. There's something called IMSI, or microscopic analysis of sperm before they are injected into eggs. We don't do this, and in fact, one of my colleagues in St. Louis, Dr. Molina Dial, a friend of mine at the Share Institute, I did a nice paper on this a couple of years ago, and she showed no benefit of selecting sperm microscopically versus selecting them with the typical wash and swim up methods that we use already. If someone wants to take the extra time it takes to microscopically select sperm, be my guest, but charging extra for this is of no proven benefit and is certainly not cost effective. A revolutionary advance in IVF is something called PGT, pre-implantation genetic testing. This is a procedure that allows us to biopsy embryos before we transfer them into the uterus, and generally we do this before freezing them or cryopreserving them. There's a lot of initials for this. PGTA is pre-implantation genetic testing for aneuploidy, which is essentially testing for abnormal chromosomes, and that's what we're doing most of the time. You can test embryos for other genetic defects and diseases, and certainly that offers advantages apart from just pregnancy success rates. Now, A lot of scientists think that you cannot make a statement without having something called a double-blind, controlled, prospective study. And I think that shows ignorance of the concept of knowledge. The sun is going to rise in the east tomorrow. I would stake my life on it. It's going to happen tomorrow. We all know it's going to happen tomorrow, and there's no way to do a double-blind, prospective, placebo-controlled on that fact. There are some things that we learn in life that are not based on this. Now, what we know scientifically, just like we know the sun rises in the east, an embryo with abnormal chromosomes will not be successful. Now, we also know, based on basic science, that about half of the embryos humans create, generally in an infertility practice, do not have normal chromosomes. It makes no sense to transfer embryos that have abnormal chromosomes. They're only going to fail or create miscarriages and lots of heartache. These create risks, loss of time, and they need to be avoided. The reason success rates have gone from about 50% in the best IVF clinics to up around 70-75% like we see is because we are not transferring these embryos that have abnormal chromosomes. Now, people will argue about the accuracy of this PGT testing of the embryo biopsies, and I'm not going to go into the actual numbers here, but in plain English, the embryo biopsies are exceedingly accurate. They're tremendously accurate in determining abnormal chromosomes, and they're helping us and helping our patients make decisions. Also, results of embryo biopsies are letting us manage the embryos that we have frozen. Our goal at Missouri Fertility is to have women and couples have all the babies they want from one egg retrieval. From one egg retrieval, we can make many embryos. And if we can test these embryos and find out which frozen embryos in fact are viable, couples and patients can make long-term management decisions based on how many good embryos they have in the freezer. There are occasions where people do not make many good embryos. And in this case, sometimes we go time out. We've only made 1 or 2 good embryos from this egg retrieval, and rather than go on and establishing a pregnancy, we might do something called embryo banking or embryo accumulation, where we actually do IVF again and again until we have enough normal embryos that we can then use to establish pregnancies in the future. If a woman is 37, 38 years old, makes a good embryo, she gets pregnant from IVF, and if she comes back for a second baby, she may be 40, 41, 42 years old before she does so, and she may be out of eggs. So it's very important to know if we have normal embryos when a woman is as young as she will ever be, because that allows us to make embryos at the best time. So for this reason and many other reasons, we feel that pre-implantation genetic testing is absolutely essential for giving us confidence to transfer single embryos, to maximize success rates, and to minimize miscarriages. There's something called physiologic ICSI, that's injecting sperm into eggs that have been selected in a special way. Once again, we find that there's no advantage to doing this, and we agree with the HFEA organization in the UK on this. PICSI does not have any benefit and should not be charged extra for this. There's also a field of study called reproductive immunology. There are a few doctors in the United States that claim to have extra information or knowledge about immune factors as it pertains to IVF success rates. For the most part, I have found their work to be very substandard, and I've been very disappointed by patients that I have seen that have gone to see reproductive immunologists. These doctors will frequently give injections of immune-modifying medicines, concoctions of oils, immune globulins. These are all very expensive, they have side effects, and they have no proven benefits. So until a well-done study has been performed and we have information on this, charging extra for injections of things called lipids or immune globulins certainly have no role in routine IVF practice. Now let's talk about the subjects that were given an amber warning. This is a little less severe, but still deserve discussion. The first is oocyte activation. These are chemicals that will make the egg work better purportedly. We don't do this. We find no need to do this. A good egg will activate on its own like it's supposed to. Charging extra for this makes no sense. Another very popular trend is to freeze all embryos, and that means when a woman is doing IVF and she hopefully makes embryos, that they are all frozen and then used in subsequent months. That's the way the pendulum is swinging nowadays in early 2020. Here at Missouri Fertility, we never went to a freeze-all policy. Our success rates with fresh embryo transfer in properly chosen women have always been excellent. They've been spectacular, in fact, and if it wasn't broke, we weren't going to fix it. If a woman has had a fairly normal stimulation and her hormone levels have not gone too high, if her uterus has been prepared, and if her progesterone has not gone too high, we still do fresh embryo transfers and our success rates are fantastic. So we're probably doing about 80% frozen, 20% fresh nowadays. And I imagine that we're going to do this for the foreseeable future. So freeze-all policies, I would certainly caution against them, although most of our embryo transfers nowadays are from frozen thawed embryos. Some people have practiced with something called embryo glue. There's no good benefit to that. Certainly you shouldn't charge extra for that. And embryos make their own glue. They've evolved to stick in the uterus, and a good embryo is going to stick just fine. Glue is not necessary. We don't use it, and like I said earlier, we have spectacular success rates not using embryo glue. Now, something that's a little more controversial is the concept of scratching the lining of the uterus, preparing the uterus for embryo transfer. Well, there's a concept called reductio ad absurdum, and what that means, you reduce a concept to something that's so small it becomes ridiculous. So I want to back up and talk about preparing the uterus. The uterus must be prepared properly to maximize the chance an embryo is going to stick in it. To that end, in our clinic, we do something called a hysteroscopy, generally the month prior to an embryo transfer. This involves putting a little telescope in the uterus. And we are accomplishing a lot, way beyond just scratching the lining of the uterus. We are washing out the endocervical canal. We're making sure that if there's any C-section pocket material that's inflammatory, we're washing that out. We're dilating the canal of the endocervix just a tiny bit, but that's all that's necessary to facilitate a very smooth embryo transfer in the following month. When we do go up inside the endometrial cavity with a hysteroscope, we scrape down any lumps or bumps. We wash out any abnormalities. We optimize the inside of the uterus. So if someone is just putting a biopsy catheter in the uterus just to scratch it a little bit the month prior to embryo transfer, I suspect that doesn't have much benefit. But when we prepare the uterus, we're going far beyond just scratching the endometrium. We're preparing the entire reproductive tract for embryo transfer, and I believe that is a big part in our tremendous IVF success rates. Something other labs are doing is they are using very expensive, we call them boxes or little tiny incubators that have little cameras on them. One of the name brands for this is something called an embryoscope. It allows us to watch each embryo grow, take a little videotape of it, and purportedly that can be used to choose the best embryos. Well, right now in early 2020, there's no scientific basis for doing this. There's very intriguing data coming from very powerful computers using artificial intelligence to pick the best embryos. And in fact, once that's been shown to be beneficial, I foresee that being an important part of IVF practice and something worth paying extra for. But as it exists right now, taking standard pictures, looking at rates of development and whatnot, there is no benefit from using an embryoscope in IVF success rates, and charging extra for that, giving false hope with this technology is certainly unethical. We do not use embryoscopes in our practice, but I assure you as soon as there's a scientific basis for doing it, we will begin using it as well. But right now it's an unnecessary expense, and we're not going to pass that expense on to our patients unnecessarily. So there you go. There's a discussion of the HFEA warnings about add-on IVF procedures. We've talked about the things we agree with. I've talked about a couple of things that I vehemently disagree with. And hopefully as we move forward, we'll all come to agreement internationally on what truly is helpful in maximizing IVF success rates. I hope you found that interesting. Thanks for watching my video. Please feel free to comment, like, and subscribe.